Welcome to our video on postpartum hemorrhage overview, uterine rupture, and inversion and lacerations. Let's get started. Let's start by covering some broad concepts about postpartum hemorrhage before diving into its specific causes. Postpartum hemorrhage, or PPH, is defined as a blood loss of greater than 1,000 milliliters after a vaginal delivery or C-section. General risk factors for this include a prolonged labor course, an instrument-assisted delivery, such as with forceps, delivery of a baby that weighs more than 4,000 grams, presence of a hypertensive disorder of pregnancy, such as preeclampsia, and induction of labor. To put these all together in your head, you might imagine a patient that is induced because of preeclampsia and subsequently undergoes a long labor before the forceps-assisted delivery of a large baby. Many of these specific risk factors will make more sense as we go along. The exact amount of blood loss is probably less important in a question stem than being able to recognize the findings that are associated with blood loss. This is true for any patient who is bleeding, not just the one suffering from postpartum hemorrhage. As the blood volume decreases, patients become hypotensive because there isn't enough fluid around to keep the pressure up. The heart's response to this low blood volume is to pump faster, and patients become tachycardic. The loss of red blood cells from the body means a decrease in hemoglobin and hematocrit. As the body's tissues receive less blood flow, ATP production is decreased, resulting in hypothermia, and the body turns to anaerobic metabolism, causing an increase in lactate and a resultant acidosis. Hypothermia and acidosis are late-stage findings that indicate the need for rapid intervention since patients can die from blood loss. Here we see a slide highlighting the causes of postpartum hemorrhage, which some students remember as the 4 T's. This mnemonic groups the causes into one of 4 categories: trauma, tone, tissue, and thrombin. It can be helpful to have these in mind as you assess patients with PPH where the cause isn't yet determined. We'll be sure to highlight these as we go. Also know that this video is focused only on the top one, trauma. Tone, tissue, and thrombin are covered in the next video. So here's an overview of the 3 diagnoses that we'll discuss in this lecture. As mentioned, these all fall under the first of the 4 T's, which stands for trauma. I'll start with uterine inversion. This illustration depicts uterine inversion. Uterine inversion is when the uterus folds in on itself. This can occur to varying degrees, from a simple inversion where the uterus can't even be seen at the level of the cervix to a complete prolapse out of the vagina. The exact pathophysiology is not well understood. Here we see another image of uterine inversion. 2 of the biggest risk factors for this are uncontrolled traction on the umbilical cord and excessive fundal pressure. If you deliver a placenta as a medical student, your resident will make sure you know this. Macrosomia, or a baby weighing more than 4,000 grams, is another risk factor for this. Placenta accreta, where the placenta implants deeper than normal into the uterus, and a fundal placenta can also predispose a patient to uterine inversion. Finally, an abnormal labor course, one that is either too long or too short, have been associated with this. Now let's discuss an algorithm for postpartum hemorrhage that we'll use throughout this lecture as we talk through each of the condition's clinical presentation, diagnosis, and management. The first step in a patient who is bleeding after delivery is to evaluate the position of the uterus. If the uterine position is abnormal, meaning it isn't felt as a firm knob below the umbilicus, we need to assess whether or not the uterus is even inside of the abdomen at all. For patients with uterine inversion, the uterine position will be abnormal, so the uterus will not be palpable within the abdomen. Instead, a mass will be seen protruding from the cervix or the vagina. As this diagnosis is sometimes confused with a prolapsing fibroid, the inability to palpate the uterine fundus is critical to making the diagnosis. In some circumstances, the uterus may fold in on itself, but not be protruding through the cervix or prolapsing with the vagina. Because of this, it's important to recognize these other clinical symptoms of uterine inversion. Patients may experience severe abdominal pain, profuse bleeding with clots, and hypotension. This diagnosis is purely clinical and can be made at the bedside without the need for radiographic imaging. So returning to this slide, we can see that management of uterine inversion includes stopping any uterotonic medications that are currently in use and manually replacing the uterus. The placenta should not be removed until the uterus has been replaced. All right, let's reinforce this with a question. Why should we stop uterotonic medications such as oxytocin in a patient who has experienced uterine inversion? Okay, so the most important thing to do for these patients is manually correct the inverted uterus as soon as possible. To help facilitate this, we need the uterus to be relaxed. Stopping the uterotonic medications helps with this. In some instances, we may even add uterine relaxants, such as terbutaline and nitroglycerin. We have to be careful though, as relaxing the uterus too much could lead to uterine atony and further bleeding. So the reason we hold the uterotonic medications is to relax the uterus to better facilitate manual replacement. Here we can see an image depicting the manual replacement of an inverted uterus. One hand can be placed gently on the abdomen to provide support, and the other hand is used to grasp the inverted uterus within the vagina. Significant upward pressure is applied with this hand in the direction of the umbilicus. Finally, this hand should transition to forming a fist to ensure that the entire uterus is adequately replaced. Alright, now let's talk about uterine rupture. We'll discuss this briefly in this lecture, but a more in-depth review of this topic can be found in our video on antepartum hemorrhage. Uterine rupture is when the uterus opens up during the labor process. The number one risk factor for this is a history of a prior C-section, because the area that was cut open forms a weakened scar. The typical presentation is a popping sensation within the abdomen, accompanied by intense abdominal pain, back pain, vaginal bleeding, and unstable vital signs, such as hypotension and tachycardia. On physical exam, an irregular protuberance can be felt within the abdomen. This is a part of the baby as it begins to escape through the opened uterus. These patients require an emergent C-section and are in danger of significant postpartum hemorrhage. Alright, let's try another question. In a patient who suffers a uterine rupture, what will happen to the fetal station? To answer this question, we need to have a basic understanding of the concept of fetal station. Fetal station is a system used to describe the position of the baby's head relative to the ischial spine of the mother. Zero station is when the top of the head is level with the ischial spine. Negative values are given when the baby's head is located superior to this landmark, with bigger numbers being further away. Positive values are given when the baby's head is located inferior to this landmark, with bigger numbers again being further away. In the case of uterine rupture, the opening up of the uterus provides an alternative pathway for the baby, and the fetal parts will often move through it. As such, the baby moves up in the pelvis, and the value of the fetal station becomes more negative. In question stems, this will often be referred to as the loss of fetal station, which is also the answer to our question. So, reviewing these points on our algorithm, this is the patient with a relatively normal position of the uterus that experiences a sudden loss of fetal station during delivery as the uterus ruptures. Treatment is with emergent C-section. Okay, let's move on to our final topic, which is genital tract lacerations and hematomas. Post-delivery lacerations are breaks in the epithelium that can bleed significantly. These can occur at the perineum, labia, periurethral area, deeper vagina, and cervix. In the case of hematomas, a blood vessel ruptures and bleeds, but the epithelium is not broken, so the blood pools below the epithelial layer. This image helps to illustrate the major blood supply of the uterus, cervix, and vagina. The internal iliac artery branches into the uterine artery, which supplies both the uterus and the cervix, and the vaginal arteries, which supply the vagina. During pregnancy, blood volume is increased to this already highly vascularized area and thus has the potential for significant bleeding from any sort of laceration incurred during childbirth. Risk factors include anything that can cause trauma to the birth canal. This includes performing an operative vaginal delivery, particularly if forceps are required. Cervical lacerations are a unique type of bleed that can be particularly brisk and dangerous. This may result from a rapidly dilating cervix or strong expulsion efforts during labor. Hematomas are more likely to occur in individuals who give birth to a large baby or those that are nulliparous, meaning this is their first child. Okay, now let's focus on the far right segment of the algorithm. So in a patient who does not experience a sudden loss of fetal station during delivery and has no history of easy bleeding, we should evaluate whether the fetus and placenta were incompletely delivered. If not, particularly if a mechanical delivery was performed, there is a visible laceration, or we feel a vaginal mass, the bleeding is likely due to a genital tract laceration or hematoma. This is a clinical diagnosis based on the presence of a hematoma or lacerated area on physical exam. The physical exam should be thorough and include an evaluation of the cervix. Here we see an image of the female perineum with the urethral orifice on top and the rectum down below. In the middle of this, we see a large vaginal laceration, such as may occur following childbirth. First-degree tears include only the vaginal epithelium. This appears to be a second-degree tear as it involves the perineal muscles that sit deep to this, but not the anal sphincter. Were it to involve the anal sphincter, it would be a third-degree tear. Fourth-degree tears include the rectum, which is not the case here. This is something they may ask you about on your labor and delivery rotation, but is unlikely to appear on step 2. The most important management step in these patients is to immediately repair any visible bleeds. Hematomas are usually managed expectantly unless the area is expanding, in which case it may be worth opening it up and ligating the affected vessel. All right, let's try another question. A patient who underwent a forceps-assisted vaginal delivery is now complaining of pain in her lower back and rectum. Physical exam of the vagina and cervix shows no evidence of bleeding. Hemoglobin and hematocrit are 6.3 grams per deciliter and 19.1% respectively. What is the most likely diagnosis? All right, you should immediately notice that this patient is bleeding given her H&H of 6.3 and 19.1. The first source for this that you might look to, particularly in a patient with an instrumental assisted delivery, would be the vagina or cervix. We don't see any evidence of bleeding at these sites on physical exam. Because of this, she is likely bleeding internally. Given that she is experiencing pain in the lower back and rectum, the most likely diagnosis is a retroperitoneal hematoma. Let's quickly draw this out. Here we see a coronal section of the abdomen. Notice the internal iliac artery with the uterine and vaginal arteries branching from it. During childbirth, the uterine artery may be damaged, causing blood loss. This blood can then pool within the retroperitoneum, which is a large potential space forming a retroperitoneal hematoma. When this occurs, patients can experience a significant drop in their hematocrit as well as rectal and back pain. This is also commonly seen in the setting of severe trauma. A consult to interventional radiology may be required with embolization of the affected artery to stop the bleeding. All right, we'll conclude this lecture with one final question. A patient presents to the clinic 1 week after a delivery complicated by postpartum hemorrhage with anorexia, hypotension, and an inability to breastfeed her child. What is the most likely diagnosis? All right, this is a classic description of Sheehan syndrome, which is a complication of postpartum hemorrhage that's worth knowing. Sheehan syndrome is the result of ischemia to the pituitary gland. During pregnancy, the pituitary gland becomes enlarged, and its function can be significantly reduced if it doesn't get adequate blood flow during a period of maternal blood loss. Patients with this pathology will show symptoms that are specific to the deficient pituitary hormones. Low ACTH can lead to anorexia and hypotension, as seen in our patient. Low levels of prolactin result in difficulty with milk production, which was also noted in the question stem. Low FSH and LH manifests as amenorrhea, hot flashes, and atrophy of the vagina. Decreased growth hormone means less lean body mass. Low TSH can lead to fatigue and bradycardia. Treatment is to replace the deficient hormones, although bringing back the ability to lactate is not feasible. And that concludes this section.